Hey everybody, Dr. Rob Silverman here. I've got my good friend, Dr. Michael Jurgelewicz. He is without question one of the leaders in the functional medicine movement. He's a chiropractor like myself, and I'd like to just jump right in. Mike, how you doing today?
Good. How are you? Thanks for having me, Rob.
Oh, it's my pleasure. I'm excited to hear what you have to share. I've got my pen and pad ready. I'm ready to learn. Everybody knows already that we're going to talk about autoimmune disease. So let's dig in and really get to the point. What triggers an autoimmune disease?
Well, I think one of the things we have to really think about in most autoimmune conditions is there are typically multiple triggers that tend to chronically stimulate the immune system over a long period of time in multiple different ways. And essentially, the immune system gets overloaded, overwhelmed, and then really it doesn't have the ability to function. So obviously, there can be a mistaken identity where the body attacks itself. There can be a virus where there's tissue destruction and appears to be foreign to the body. There can be some heavy metal type issues. There could be molecular mimicry, which we see a lot, where this occurs when the body makes an antibody to a different protein that attacks other objects that appear to be foreign to it, to a specific antigens. And we see a lot with different immune dysfunction with food sensitivities as well as intestinal barrier dysfunction. And so essentially what happens is these antigens or proteins can resemble certain proteins in the body. And essentially the body makes these antibodies to attack our own tissues.
Hey, Mike, we got somebody. Hello. We've got a fan from Kuwait. Keep the awesome work going, guys. Love watching all your videos. So let's get back into what you said. You really gave a great landscape of why autoimmune conditions. So I also, I'm getting some questions here on my phone, and they're like molecular mimicry. Could we go into more detail? So a molecule mimics another molecule. Your immune system gets confused and attacks not only that molecule, but something in the body that's adjoining. So for instance, gluten has a tendency to get confused with the cerebellum. Could you expand on that a little for everybody? Because everybody always asks about molecular mimicry and what's the basis of it? Why does that occur? How does that again lead to that autoimmune condition?
Yeah, so I mean, essentially, I think we might even take a step back a little bit. But when you're looking at autoimmunity in general, you have the development of different T cells, and so there's genetic components that play a role, environmental factors, stress. But when you're looking, a lot of times when we think about these antibodies that we're talking about with molecular mimicry, they're made by the B cells of our immune system. They're responsible for making these autoantibodies. But really, um, just the presence of the antibodies that kind of tags the tissue for future destruction. But it's really this T cell response that that is causing the destruction. So essentially, a lot of times when we talk about different nutritional therapeutics that we can give someone, we're really talking about how can we influence what we consider like T regulatory cells. But there are many types of T cell groups, such as double negative T cells, Th1 cells, Th2, Th9, Th17, which we see a lot with different dietary influences, and then our T follicular helper cells. So there's lots of these different immune cells that play this role. But when you're looking at those molecular mimicry, essentially when we have autoimmunity, it's like this perfect storm. So we can't change the genetic predisposition, right? But we can essentially address any sort of intestinal barrier dysfunction, as well as the different environmental factors. And those environmental factors, I mean, there's obviously external factors, there can be endogenous factors. And unfortunately, and many times, we're going down a rabbit hole of trying to figure out what are those 3 to 5 things that is causing the dysfunction in those individuals, and then we can address it. So a lot of times when you're seeing these issues with these antibodies making immune complexes, I should say, to those different proteins, a lot of times, why does this occur, somewhat so easily? I mean, you have besides the genetic component, there's potentially dysbiosis, the standard American diet. There can be other types of, xenobiotics or pollutants, medications, non-steroidal anti-inflammatories. But essentially what happens, and some people don't think about this as much, but in the actual stomach and the colon, the mucus layer that is believed, between the epithelial cells essentially, and the bacteria is 2 cell layers thick. But when you have the small intestine where you're absorbing nutrients, it's only one mucus layer. And so essentially the bacteria make contact with the epithelial layer. And what do you have on the other side of that? You have your bloodstream and your immune system. And so what happens is when there's that compromise, whether it's to lipopolysaccharides, gram-negative bacteria, other types of things, then you make those immune complexes to that. And it doesn't happen with just autoimmunity. It can happen with a lot of other issues as well.
Yeah, that was a great description about the single layer epithelial cell, which has the thickness of a wet paper towel, and it's permeable, if you will. It's when it becomes too permeable, it becomes leaky, if we could use that word, or increased intestinal permeability. So you gave a great description of how things can pass the gut and get to the bloodstream where your innate and adaptive immune system exists. And then, as you said, it tags and targets specific molecules, especially food proteins. Now, you gave a whole litany list of things, which is really interesting, that cause autoimmune disease. But can you give some examples, not only of that, but some common autoimmune diseases as people wouldn't know? For instance, we'll spot you the obvious. We'll call lupus one of them.
Yeah. So if you're talking about more environmental factors, I mean, obviously, we talked about you can't change, or I say an endogenous factor, you can't change your genetic predisposition, but many times this is going to happen more typically in females, just because we think, or at least some of the research points to possibly like testosterone levels, but there can be issues with other hormones and vitamin D insufficiencies, other types of infections, toxin pollutants, smoking, dietary, different adjuvants, and so there's a lot of these things that we have to look at, even stress, and think about, what are the 3 to 5 things in these individuals that, is causing these issues. And so, and obviously use different types of potential laboratory type tests to assess some of that dysfunction. So a lot of times we're looking at doing some of the same testing from the traditional labs that most practitioners are using, but realistically, to identify the dysfunction and how to address these things from a nutritional standpoint, we really have to look at some of the different specialty labs, as far as looking at like GI, intestinal permeability, and other things. But to your point, like, what are common autoimmune conditions that most of us are probably seeing? I mean, there's tons of autoimmune conditions around lots of specialties, but at least what I tend to see a lot of, obviously inflammatory bowel disease, Hashimoto's for thyroid, that you mentioned lupus, and so those tend to be probably the most common, just because, unfortunately, rheumatoid arthritis, obviously, but a lot of these tend to fall through the cracks of traditional medicine. And then I also think the unfortunate thing is, and because there are obviously medications out there that can help with disease management and symptom maintenance, but the problem we have is these individuals are not being told that they can change the trajectory or the progression of their condition or their dysfunction at the time by making dietary changes, lifestyle, and nutritional therapeutics. And I think if a lot of those individuals knew that they could do those things, or from an integrative standpoint, do those things together, because a lot of people will see us at different times across the course of their condition. So you may have someone with rheumatoid arthritis that's been following the standard of care for 15 years, but they still have joint pain. So the whole point is the standard of care is not working. And many times, by making, if you don't change the environment, of course the disease is going to progress. But if we can do all of those things, we should be able to dampen that immune response.
So patient comes in, give me your baseline 3 tests that you're going to do to try and ascertain whether they have autoimmunity or not. That was one of the questions I just got.
So, well, there's a couple things here, and we kind of alluded to this in the very beginning, but there's tests obviously that we're going to look at for optimal health, regardless. That's going to play a role with helping with the autoimmune response, and so that's different than what tests we're going to look at for autoimmune. So, there are labs out there that can do, I would say, antibody screens, right? So you can do different looking at those different. I mean, obviously there's a cost associated with it, but you can screen for, different connective tissue panels, depending on what type of proteins you want to test for. But I would be looking at more of these, screening the autoantibodies as predictors of future disease. And because what we know, for example, I'll just give Hashimoto's for example, many times, the research shows us that the antibodies for thyroperoxidase will show up 7 to 10 years before it affects TSH. And there's a 97% chance that they're going to have Hashimoto's with the positive antibodies. So if we know there's a 7 to 10 year window, instead of waiting for destruction and then the TSH to increase and then them getting put on medication, we have that window to investigate these things. So besides looking at the antibodies because many times if the antibody's present, it doesn't mean that they're diagnosed with it. It just means that they have autoimmune dysfunction at that moment, and you want to address that. But other things that you look at, besides looking at the detailed testing, you obviously want to look at like vitamin D deficiency, omega-3 fatty acid, like an omega check. A lot of people will take fish oils, but as we know, they'll just buy a product that says a 1200 milligram soft gel on the front of the bottle. Then you look at the back of it, and it's one soft gel is 320 milligrams of EPA DHA, which is they need about 10 of those to get 3 grams of EPA DHA to get probably a maximum omega index around 8%. So many of them are just not taking a therapeutic enough dose to make that work. But again, just addressing those two things, the vitamin D and the fish oil, is that going to be the game changer? No, but it's part of the multifactorial approach. And, we know monotherapies don't work in traditional medicine. And so it's really trying to plug those 5 to 6 holes in the roof, right? So the vitamin D and fish oils are two things you have to optimize in everyone. But, other things that people think about from a therapeutic standpoint, I mean, there's obviously curcumin, resveratrol, things like that we can consider. But as far as testing, there are specialty labs that can look at intestinal permeability assessments where you're looking at zonulin, actin, lipopolysaccharides, occludin, all the different specialty labs that will test where you can do stool testing. You can add zonulin on there as a screen. And obviously get snapshots of the GI dysfunction that way.
Yeah, that's great. And the tests that you mentioned, some of them are more basic serum tests and others are more typical of what functional medicine type practitioners do. So you really gave a great starting point in a treatment plan for that. Got a couple of questions. People are checking in. We're allowed to talk about this. I know we said something before, but I checked this week. Somebody who follows you around asked about long COVID and autoimmunity. Is long COVID a derivative of autoimmunity? I got a whole bunch of other questions, so I'll do it in a rapid fire fashion.
Honestly, I don't know if it's necessarily like a part of autoimmunity, but I guess what I will say is, and again, we don't have necessarily the studies to say this, but I would suggest that where I've seen, at least in people that have, autoimmunity or they have intestinal barrier issues, and let's say you've been working on their gut and a lot of things have improved over several months, I've seen exacerbations, right? With like it kind of, it puts them 2 steps back, right? And then you can still kind of help them, but it gets to a point where it definitely puts a little wrinkle in the road.
Osteoarthritis. Guys, you're chiropractors. Again, I'm reading the question. We know that rheumatoid arthritis is autoimmunity. What's your feeling on osteoarthritis? It's a good question.
I think, Rob, you probably have a good answer on this, because I think I saw you write about a blog or something recently on this. But honestly, um, I do think I wouldn't say it's the same type of mechanism, but there is more and more research coming out with the gut and osteoarthritis. Is there that connection, right? And also, I do think if someone has intestinal, permeability, and they have a lot of food sensitivities, um, that can be it's causing inflammation, right? Just because when we think a lot of times, like an IgG reaction, it's inflammatory. Like IgA, that's the first line of defense. It lines your nasal mucous passages or GI lining, but it's really non-specific, non-inflammatory. But then it brings in the IgM and IgG, and I do think that, I mean, a lot of times when we think about what are the symptoms of like a food reaction, it's usually these generalized vague symptoms such as like migraine, joint pain, fatigue. You really can't categorize it in a condition, but I do think that, um, you know, if you're a chiropractor and you're just doing musculoskeletal work and you're not really into the functional medicine, you really need to be supporting your patients, at least at a minimum, from optimizing the D omega-3s, and really starting to, I think, branch into understanding the gut health, and making sure at a minimum at least you're getting people to avoid processed foods and eating products, and really shifting to whole foods. And it doesn't have to necessarily be a Mediterranean diet, but really, we have this, we're at this time where, I mean, we all see this in the grocery store where so many people are eating products, right? And these overly highly processed foods with lots of emulsifiers and all these other things, and these are foreign to the body. So you don't know how they're going to react. I mean, and it really comes down to the immune tolerance of the individual, right?
Mm.
And so that's why I think it's good to do some of the testing, and also, you see a lot of people that they want to follow these programs and protocols, and you can definitely shift things, I feel like, in the microbiome in somewhat of a short period of time, therapeutically. But when you're looking at like some of these antibodies around the intestinal barrier, if they're positive, it's not just something that just goes away overnight. I mean, a lot of people think, oh, I'm going to do a 2 month gut cleanse, and then I'm going to heal intestinal permeability. But we have to understand, a lot of these people, they may have had IBS and things for like 10 years, and they have a different level of immune tolerance than someone that was just recently diagnosed, maybe with like IBD for the first time, and like 6 months ago. And so a lot of times, at least in my experience, to see some of these antibodies shift, it usually, at least for the intestinal permeability we're talking about, it usually takes around like 4 months or so, and it's still not be completely negative. But you see the positive trend. But the whole point is, it could take like a year and a half before that gut's really healed. And I think sometimes that discussion is just not happening, because people are reading like books, and they're talking to thought leaders and other things, and they're trying to do their own research online, and those things are designed to appeal to the masses, because they're really restrictive diets, which can work, but a lot of times you may find that with someone with autoimmunity, you can simply just start with gluten by itself and have profound improvements in their symptoms, where sure, you may want to add dairy and other things, but from a removal standpoint, but you don't have to go to the opposite extreme of like restriction. And that's why I think, even though food antibody testing is you want to have it to be personalized, and I think there's value in it. And I know there's caveats with, or the tests maybe are not perfect, but I will say most of the time, patients, it makes them make a change, and usually we see, at least I've seen, really good clinical outcomes with them.
Great takeaways. It's very interesting, and I think you really started to touch on it. Everybody says, "Oh, I have antibodies. That's a good thing." It's really not. But I think the bigger thing that you really wanted to speak about, the long-term issue, is that if you have a damaged gut, it takes months to almost a year and a half, especially autoimmunity at the gut level, to fix it. And what do you do as a practitioner? How do you tell a patient, listen, you have an injury there, it's in your gut, you just can't see it. and it's going to take 18 months to heal. It's really tough. Experts like you are able to talk to a patient because they're coming to you because they've tried 5 to 15 other practitioners. But generally speaking, you and I both realize most patients shake their head and looking for somebody who'll say, hey, in 6 weeks, you're going to be fixed. And that's just not the case. And I think a big salient point is that you can have not just autoimmunity, but it's conceivable you have autoimmunity at the gut level.
Well, I think too, and one of the things that you point out there, I think people, and we do see this, we see people get symptomatically, they can start to feel much better in like say 6 to 8, weeks. You can get improvement symptomatically, like a short-term therapeutic hit. But to your point, like that's just the start, right? A lot of times there's always, now you're still at a dysfunction state. You're just not expressed as symptomatic, and they typically just need that longer term care. But I think to your point, we have to look at, and I think that's the important of testing. I mean, I know some of the testing can be an out-of-pocket expense, which can be expensive, but you're not going to really know any other way with what you're impacting, because everyone's different. And honestly, you can back a test and then you can see where it's going. And then you may say, you know what, it's going in the right direction, but I can do something a little bit more therapeutically now and change that a little bit, because the body's dynamic. And it's just like you start out therapeutically, you may also be able to reduce a dose on something. But I think a lot of these individuals, when you're dealing with the gut and you're trying to heal it, you're almost kind of giving them, like, think about that as like their multivitamin for their gut for the next year while they work on it. So
yeah, again, really, we're talking about the gut because 60 to 80% or up to 80% of your immune cells are in your gut. It's where your macro and micronutrients are absorbed. And people always ask, why is the gut have all, or is lined with all this immune cells? It makes sense because, as you said before, it's the food that we ingest. It's our number one possible toxin, number one carnage, if you will. All that being said, what population is most susceptible to autoimmune conditions?
So we actually alluded to it, earlier in our conversation, but I mean, obviously, women tend to make up probably, like, I would say 80% of that. And I do think that, part of that can be from a hormone standpoint, but I would say, at least from individuals that I've worked with over the years, it tends to be women between like early to mid 30s through 50. I mean, that's kind of the sweet spot with, a lot of times too, you can have women that become pregnant, right? And then from all the hormonal changes and things like that, they come out of pregnancy and then they never felt the same. And then they have, because you can have estrogen surges and other types of things that can cause some issues.
Yeah, women seem unfortunately to be susceptible to a lot of conditions, autoimmunity just being one of them. And you spoke about the genetic component. Excellent. You know what? I've got a couple people. How do you treat this? What's your suggestion? How do you go about it? I know you started off with testing and ascertaining, so you don't have to guess whether they have an autoimmune condition. But what do you do if you isolate an autoimmune condition?
So I think the big thing here is, obviously, we're not here to replace their primary care doctors and specialists, right? That the whole goal is for us to take snapshots of their health that the other practitioners are not looking at, and really bridge the gap, see where their physiology is not functioning, and then support that through diet, lifestyle, nutritional therapeutics. So I'm never really looking at people from like a diagnosis standpoint or saying, this is your treatment. We're not getting hung up on a label, right? And we're looking at different biomarkers that we can, address that way. And I will say, I will expand on the traditional labs or fill in the gaps where the other practitioners are not looking at. So I don't look at these necessarily as autoimmune markers, but I mean, just from my experience, there's not many practitioners that are doing the high sensitivity CRP on all their patients, right? And then, looking at A1C as well, surprisingly, and then homocysteine. And then obviously doing like an omega check. Even though people are taking fish oils, I mean, I run omega check through Cleveland Heart Lab on everyone, and it's most of their omega-3 index is between 3.1 and 3.5 when it comes back. So I don't even care if they're taking a fish oil, but because many times, what do you see? Besides what I mentioned before, oftentimes the supplement facts panel has a serving size of like 2 soft gels, and they're still taking 1 soft gel a day. So when you get the intake form and you see they're taking fish oil, it's like, oh, what product is that? Let me look at it. Okay, well, the quality of your products most likely are not that bad, right? It's just the fact of you're not at a therapeutic enough dose to do something. So the point is, I like to look at those markers. For the homocysteine, most of the people that I see have high elevated levels, and obviously we can give methylation support for that. Every professional brand has some sort of cofactors around the different B vitamins like B6, folate, B12, and acetylcysteine that supports that pathway as well. Because we have to think about it is, sure, the gut plays a huge role, but we have to look at these other nutrient deficiencies, because when people are in a chronic disease state, they have more inflammation and oxidative stress, so they have higher nutrient demands than the average person. So they're going to need something more therapeutically in that crisis, and then over time, we can back things off. But so besides the testing that I just mentioned in the blood, anytime we're looking at thyroid, we're going to screen the thyroid peroxidase and thyroglobulin antibodies. And then, like I said before, if you're not doing, many times these practitioners, these individuals are coming to us too with positive ANA, which can also just be, inflammation, as well as other, antibodies that are positive with rheumatoid arthritis and stuff. So I may do a screen if they have joint pain and it's bilateral, and I think it's systemic, and I think it's more autoimmune. And then other times they're already coming to us from, having the diagnosis. And then really, then what tests do we look at? So, we talked about the gut. It's not the only thing, but why do we start with like the vitamin D, the fish oil, the omega, and the intestinal permeability? Because those are the foundational things that are common in a lot of people. And to your point, which you mentioned before, is we're not going to just start going down looking at heavy metals and all those other things, because it's more than likely that, hey, maybe there is an issue there, but we're trying to take snapshots, based upon their symptoms and other things, where we're going to see abnormal testing and where we can make a change. And so a lot of times I'm going to bridge the gap with the traditional labs, and then I'll do usually like at least one specialty lab. And then we kind of start with that, because you might be able to knock things down like 30 or 40% just with that, and see where they get in 3 months. And then if you have to dig deeper, you can always look at these other tests. You don't have to necessarily do every single thing at once.
I agree with you. I start with the regular labs. I do a full composite of all serums, and then I usually do food sensitivities, gut barrier panels, and the like, and then we notch it up.
Exactly.
That's going to be greatly revealing. But something that you said, that's a huge takeaway for everybody, practitioners and consumers, patients alike, is that what's on the bottle is the lowest possible therapeutic dose for wellness. When they're coming in to see us or another practitioner, they're sick, so they require more nutrients. A depleted cell cannot be repleted by food alone at that point. It takes too long, hence the idea of supplementation, hence the idea of functional medicine practitioners, we need to dose a little bit higher. I thought that was a tremendous takeaway there. Most people say, well, I take a gram of fish oil. Yeah, well, maybe you and I do, because we've taken 3 to 5 to 6 grams over a duration of time to get the omega-3 and the omega-3s in the cell membrane full and get that omega check to an appropriate level. It's kind of like vitamin D. Yeah, maybe we could take 1,000 to 2,000 IUs if we were between 60 and 80, let's say. But, when people come in with, like somebody came in with 12 yesterday, 2,000 just isn't going to elevate them. We need at least 5,000. And I know you do it because we've talked about it. We dose according to condition, to the idea of N of 1, and more so body weight. We got a 350-pound offensive lineman versus a 100-pound petite female. We're not going to dose the same way. So people need to stop looking at the bottle and start taking the bottle and what's in the bottle and looking for functional medicine practitioners like yourself and others to really guide them and coach them through this process.
I also think about, for example, the vitamin D. I mean, how many times do they tell their traditional doctor to test their vitamin D? It comes back low, right? And then they go to CVS and they don't get told what dose to give, right? So they go to CVS to buy the 1,000 IU. They take the 1,000 IU every day for a year. Then they find you in your office, and then you retest their vitamin D, and it's the same level that it was when it was before in the deficient state. And it's really just, I think, because there's been this like incorrect calculation essentially with how vitamin D was, identified with, trying to say that this is what you need for the RDA. Most people, if they're probably under 40 nanograms per ml, I'm going to put them on 5,000 a day. And if they're probably less than 35, I'm putting on 10,000 a day. And then we retest in 2 to 3 months. And I think that's the important thing. It's fat soluble. You want to retest, but on top of it, one of the things that we have to understand too is there's a strong interrelationship with other nutrients. Like, for example, the fat soluble vitamins, vitamin K, and plays a huge role with D. So we should, anytime we're giving the D therapeutically, we got to make sure we're giving therapeutic doses of K to prevent soft tissue calcification. But then also, there's been some research to show that essential fatty acid levels influence vitamin D levels, as well as magnesium levels influence vitamin D levels. So it goes to the point of just, let's not just get hung on vitamin D. It's about, like, we got to optimize the whole system. And if you're getting that stuff in the diet, if you're eating a couple fillets of sockeye salmon every week, great. But like, we know the reality of like people that may not like fish, or you're in New York, I'm in Connecticut, so like the latitude that we're at, we're not going to get optimal vitamin D. We're in our offices most of the day. Most people go outside, they have 80% of their body covered, and if they don't, they're putting sunscreen on. So we have all these things to prevent that. And then we know magnesium, for example, most people, then they get it tested through a traditional lab is in the serum, where it's only 1% of the stores. If you test through a specialty lab and you're looking at red blood cell, I mean, it's not perfect, but 90% of them are, or I'd say 70%, are probably insufficient. And then it's cited as the mineral with, being most efficient. And I think part of that has to be too, because even in foods that are rich in magnesium, most people are not consuming as much. So those are just other, they're not things for autoimmunity, but I think it's, as we're touching on vitamin D and optimizing it, we don't want to, we want to know, we want people to know there's other important interrelationships with other nutrients that we have to optimize in the diet. And if you're not getting in the diet, you're going to want to do some supplementation.
Yeah, that was a great takeaway on the missing mineral, magnesium. Interesting. And, somebody asked a question. You had mentioned sort of going into a regular store to get a supplement. So, and we know that we both have involvements with specific nutrition companies, ones that we're all very comfortable with, more at the practitioner space. What are you looking for in a difference in a company to purchase a supplement versus, let's just say, the standard thing in a pharmacy, vitamin, whatever?
Yeah, so that's a good question, and I'll be honest. I mean, obviously, we both have certain biases towards professional brands because we know the quality and things like that. There are other. I will say a lot of the over-the-counter brands, they don't, from my perspective, do not have poor manufacturing quality, right? I mean, they have to probably follow GMP and other things, but here's the challenge that I get. So let's say someone's taking a therapeutic vitamin D already, and they spent money on it. If I can increase the dose of what they have left because they were not therapeutic enough, and it gets it to the optimal level, then I'm fine with them taking that product and using it up, right? I don't want them to throw away their money. But the whole point is, I'll say, let's take a look at that label. And if everything looks pretty clean on there, because some of these people are buying professional brand products, and if everything looks good from an excipient profile, because we want to go there in a second, then I'm like, you know what, you can continue with this, or I'd recommend this when you run out of that. The challenge we get in with some of the over-the-counter products that most individuals don't understand is the active ingredients actually may be really good from our perspective, But what the patient doesn't, or the client doesn't know, is when you look at the other ingredients. I had a perfect example of someone that had vitamin D and all these other things in soft gels. And then it says gluten-free on it. And so all the buzzwords that makes it look like this great product, but in the excipients, that's the other ingredient section. It lists corn oil, soybean oil. So now you're getting these pro-inflammatory type of excipients in with the product. And we know lots of people can have issues with corn because it can cross-react with gluten and other things with autoimmunity. And so other products, if they have a white capsule that's not transparent, that contains titanium dioxide, and there's some animal research in how that can induce colitis and inflammation. So it's just important, even though the products can be good from a raw material active ingredient standpoint, it can also have these other excipients in there that can be pro-inflammatory that the average person's not going to be aware of because they're not on the side of the space that necessarily we are. And then the other part of it is, many times if you're trying to support B vitamins and things, they're all containing synthetic folic acid, whereas we know most of the professional brands across the board removed synthetic folic acid from their line probably like 13 years ago, just because 40% of the population or so have different genetic SNPs where they can't properly metabolize, folic acid to a reduced form.
So somebody just asked, what supplements would you recommend for more of a foundation health nutrition?
Well, I mean, I think without testing, I mean, obviously you can cover some of your bases with like a multivitamin, vitamin D, magnesium. Those are some just basic stuff. But then I think if it really then comes down into like after you do take a few things, like what are the other areas of your health that you're having issues with? Obviously, we're talking about autoimmunity. So, clearly there are, when we think about gut support, I mean, glutamine is just one of those great amino acids. That's the main fuel of the enterocytes and, helps with intestinal barrier lining. One of the other raw materials that I really like, and it's across a lot of the professional brands, so it doesn't really matter where you get it from, but I really like Immunolin. That's a trademarked ingredient. It's a serum bovine immunoglobulin, and so we think about that for not just autoimmunity. I mean, a lot of the research is actually on like IBS, but then they have it in inflammatory bowel disease and other conditions. But so it's a concentrated, it's a non-dairy form of IgG that can help with intestinal barrier dysfunction and but I think one of the big things that I like about it is it binds different microbial antigens that a lot of people aren't aware of. So if you have a lot of food sensitivities or Candida H. pylori, they published some recent research binding some of those different proteins or those other gram-negative bacteria. And so a lot of practitioners are using that as a first line of like kind of clear and remove out, even though it supports the repair. And then I think just things like if you have autoimmunity, curcumin. I mean, give yourself a therapeutic dose of curcumin. It's so beneficial from an anti-inflammatory perspective, immune modulatory, effect. So, there are. I mean, I know these sound kind of basic, but sometimes, people want this new sexy novel thing when you're not covering the basic stuff to begin with. And I like sac boulardii a lot. I mean, people think about sac boulardii as just a temporary probiotic for traveler's diarrhea or during antibiotic treatment. But there's good small studies with IBD. There's antimicrobial and antibacterial effects with it. Around like H. pylori, some other different C. difficile, but it actually a lot of times when people take, as much as probiotics are really good, you have your lactobacillus and bifidobacter. There's some people that most of the people that we deal with, if they come in with GI issues, they've already tried the lacto and bifido, right? Sometimes people may have bloating and things with that, but with sac boulardii, it does have other effects on the intestinal barrier that you don't typically get with lacto and bifido. And it's a transient non-pathogenic yeast that, can help boost secretory IgA, similar to glutamine can, colostrum can, probiotics in general can, but and again, I think it's not that it's off the radar, but people think of it for like one or two applications as opposed to just a lot of its other, really good benefits on the intestinal barrier.
Yeah, I concur with you on saccharoilides. I love it as a yeast. I think, again, it's overlooked. I think it should be a staple in everybody's probiotic armamentarium. I truly agree with you with SBI, serum bovine immunoglobulin, like you said. I call it the mop of the gut. It's the binder. I think now, if you're using something to break up biofilm, and we won't go down that rabbit hole, you want to combine this with whatever biofilm zeolite clay that you're using. You're really going to make an indelible mark on somebody's gut, whether it's leaky gut, antibiotic resistant bacteria, SIBO, etc. So I've got one more question for you, low hanging fruit for you. I'm always usually low on my vitamin D levels. Should I take it year round or just in the winter? I do live in New York.
So this is sometimes like a frustrating thing for me because I don't understand why people think we should only take it just in the winter, right? They think that we're doing it preventively around wintertime. I get it when it's going to drop, but I mean, I can tell you right now, there's so many people that I test in the summer and their vitamin D's low, right? Because they're not living a lifestyle that's outside. And we know if you live by the equator, I mean, if you're looking at vitamin D counts on the research, if you live by the equator, you can get close to, like if you're a farmer in the equator, you get close to 100 nanograms per ml if you're outside. But there's so many factors that play a role. I mean, there could be, body fat, the color of our skin, to all these different factors, genetic components. I mean, if you have certain VDR SNPs, where you may need a higher amount. But so I typically have people on the same dose all year round because I've never seen people really at that therapeutic dose, say in the winter, it has never driven them up high to like a toxicity. And I don't know what it is, but the reference range through like Quest and LabCorp is like 30 to 100 nanograms per ml, right? So like if you're a traditional doctor and you're 31, your vitamin D is perfect, right? So but the point is, like, I'm shooting typically for like that 50 to 70 range. Because I saw a study in the Journal of Immunology back in 2014, and they showed the maximum anti-inflammatory immune modulatory effect happened once you hit the 50 nanogram per ml concentration. But then to the point is, if you think about toxicity, let's say someone accidentally went over 100. When you Google vitamin D toxicity and you see all these like really bad symptoms, to get those symptoms, you really got to get that vitamin D level up to like 250, 400. You're not going to do that just because you went outside the lab range. So, and I've never done it with 10,000 IU in a capsule per day as an upper limit per day. But I mean, the only time you probably can see like a spike or go past that temporarily where it's still not bad, you just have to drop it back, is when you're doing some of the emulsified liquids sometimes, because again, you're kind of bypassing the GI a little bit. It's emulsified, it's typically mycelium or something, and then you're going to kind of get it through the thoracic lymph, and it just. So if I have people with gastric bypass or other individuals that have trouble getting their vitamin D up and they're taking a 5,000 or 10,000, like, hey doc, I can't get my vitamin D up. Every single time I put them on a liquid D and put them at like say 6,000 or 8,000, I haven't had one person where I wasn't able to drive it up. So I think that's where you just have to look at, like, be more creative and try different forms.
Yeah, I agree. I mean, I've had a couple of patients that were dosing pretty high in their 140s. We did pull them back. I read that article. I agree with you. But for instance, with COVID-19, they found out there was no death, vaccinated or non-vaccinated, if your vitamin D level was over 50. So it's a statistical zero. So 50, you like 50 to 70, I like 60 to 80. But the bottom line is 30 is not enough. But
Exactly.
Don't get upset if you're in the 90s. It's okay if you get an A+ on a test. I mean, we're not going to take points away.
I think one of the things that's important is, like, and this was always my frustration when I see the studies on like vitamin D. Like if someone gave like 2,000 IU of D and they showed it effect, but they never really talk about like, the levels. And, interestingly enough, there was a study published in August of 2022. So, about 6 months ago, and it showed that it talks about, specifically it was an update on the effects of vitamin D, immune system, and autoimmunity. And it said the current recommendation to increase vitamin D intake with enough sunlight exposure, at 30 nanograms per ml, but it said better at 40 to 60 to obtain an optimal health. And that's one of the first times I kind of seen in the study where they're recommending that this higher dose. And then there was a study published last year on vitamin D and omega-3s on the incidence of autoimmunity. It was the VITAL study, and they basically showed that vitamin D supplementation for 5 years with or without omega-3s reduced autoimmune disease by 22%, while omega-3 fatty acid supplementation with or without vitamin D reduced it by 15%. So essentially, if you're optimizing both of those, nutrients, you essentially can, from a preventative standpoint, have almost like reduce that incidence by about a third.
Great data, great articles. I mean, it really speaks to what the functional medicine, functional nutrition world is doing. I know you're crazy busy. I really appreciate you taking some time. Lastly, someone wants to further this conversation, talk to you, how can they get in touch with you?
You can just, shoot me an email. I can always give that to you, Rob, unless you want me just to.
No, give it out. Be my guest.
Yeah,
We can put it in the show notes also.
Yeah, so I mean, my personal email is Dr. Michael Blair, Dr. Michael Blair, BLAIR @gmail.com.
It's funny. My wife just said, I jacked. It's funny every time we talk about vitamin D in high levels. She just said, how detrimental is to have my vitamin D level in the hundreds? And Dr. Mike just answered. He said, it's not. We've peeled back a little bit. So everybody else.
Yeah, I'll be honest. I mean, I've shot a few people up to around like 150. But again, like they started really low at like 30, right? And we did a liquid therapeutically. As soon as that comes back, like 2 or 3 months later, we just cut it back. We just stopped for 3 to 4 weeks, and then we start them at like say 2,000, and then we retest it again. So I think the important part of this is just you're not just giving therapeutic stuff blindly. You're coming back and you're changing that course because everyone's going to have a different absorption.
It's funny you said that, and I know that I'm taking a little of your time, but that's exactly what happened. She was moving slowly, 30s into 40s. Then we didn't test for 6 to 9 months, and then all of a sudden it all popped. And that's exactly what we're doing, bringing it back to 100, which everybody remember, you've got to test and not guess. Just don't arbitrarily give people 5, 10, 20,000. There are docs out there that do some IVs with 50,000. It's a substantial amount. Supplements are potent and they work in the same pathways as drugs. I think that's for another day. We got to get you back on again. I appreciate all that you brought, everybody. Dr. Mike, anytime you need anything, the man is a true expert. I'm Dr. Rob Silverman, always yours in health.
Thanks, Rob.